Welcome, CyberMDs, to another cardiology lecture for the USMLE Step 1 exam. Today's lecture will cover heart failure. We'll discuss the underlying etiologies, exam findings, risk factors, epidemiology, diagnosis, and treatment options. Before we get started, please remember to like, comment, and subscribe if you find the content here useful at all so that we can continue our mission of providing free medical education resources to students around the world. Additionally, please let your friends know about us if you think our content's useful. And if you think we can improve on any way, please let us know. Now, let's dive into the lecture. Alright, so CHF, also called congestive heart failure, or heart failure for short, can be classified as right-sided, left-sided, or biventricular, depending on the affected heart chambers. Simply put, this is a failure of forward flow of blood due to ineffective pumping of the heart. The heart, which is a pump, fails. The risk factors for heart failure are numerous and can be categorized into modifiable and non-modifiable factors. Non-modifiable factors such as age, gender, ethnicity, genetics, and family history are all things that our patients cannot change. However, modifiable factors such as coronary artery disease, hypertension, diabetes, obesity, smoking, alcohol, and drugs are all lifestyle changes that our patients have control over. These are all things that as age increases, male gender, if you have any kind of family history of this condition, or if you have any of these lifestyle factors, these are all going to be things that increase your risk for heart failure in the long run. Heart failure is a significant public health concern with increasing prevalence globally. I believe as of 2021, it's estimated that more than 26 million people worldwide are living with heart failure. The prevalence is similar in men and women and increases with age, affecting about 1 to 2% of adults and over 10% of those 70 years and older. In the United States specifically, heart failure affects approximately 6.2 million people ages 20 and over based on data from the American Heart Association. The incidence is actually higher in African Americans compared to Caucasians, and it's also higher in men compared to women, specifically in the United States. The prevalence of heart failure is expected to rise due to the aging population and improvements in the management of conditions that lead to heart failure, such as a myocardial infarction or the coronary artery disease that we mentioned earlier. Despite advances in treatment, heart failure still carries a really high mortality rate, with about half of individuals diagnosed with heart failure actually dying within 5 years of their diagnosis. So let's talk about some causes of left-sided heart failure. So left-sided heart failure, which is the most common form of congestive heart failure, may be the result of several pathologic processes that hinder the left ventricle's ability to efficiently pump blood forward out to the body. Ischemic heart disease is a leading cause of left-sided heart failure. In this condition, you have atherosclerotic plaques that obstruct the coronary arteries, compromising the blood supply to the myocardium, leading to a heart attack. That heart attack causes the death of myocardial cells, and then that area is replaced by a fibrous scar. And that scar tissue lacks the contractile properties of the healthy myocardiocytes, thereby reducing the heart's ability to pump efficiently. Another cause is hypertension or high blood pressure. Chronic hypertension makes the heart work harder to pump blood, which leads to hypertrophy of the left ventricle. Over time, the hypertrophied left heart muscle becomes stiff and less compliant, causing a form of left-sided heart failure known as heart failure with preserved ejection fraction, sometimes called HFpEF, HFpEF. This is a form of diastolic heart failure because that ventricle is very stiff. It has a difficult time relaxing and therefore a difficult time filling, and then you're not filling as much, so you're not ejecting as much. Total blood volume, even though your ejection fraction is preserved, and in that case you have a left-sided heart failure. You can also have cardiomyopathies leading to left-sided heart failure, which are diseases of the heart muscle, and again, these can lead to left-sided heart failure, such as through a dilated cardiomyopathy, which is one of the types of cardiomyopathy, which is often a result of a viral infection or genetics or alcohol abuse. And that's going to involve those ventricular chambers actually enlarging. So they get really big, and that actually compromises the ability of the blood to pump efficiently and effectively. On the other side, though, you can get a restrictive cardiomyopathy, and that's often going to be due to like a infiltrative disease such as an amyloidosis or a sarcoidosis, and that's going to also result in a stiff ventricle that restricts the proper filling during diastole, like I talked about earlier with regards to heart failure with preserved ejection fraction. All right, let's talk about some clinical features of heart failure. One of the most significant clinical features is going to be dyspnea, which is shortness of breath or difficulty breathing. This dyspnea often occurs or presents initially on exertion and can progress to occurring at rest in severe cases. The mechanism behind this symptom is related to increased fluid accumulation in the lungs, called pulmonary edema. And that's going to result from the inability of the left ventricle to efficiently and effectively pump blood out of the heart forward, so some of it builds up backwards or behind the left ventricle, and that's going to lead to increased pressures in pulmonary circulation. Because they have this fluid in their lungs, patient may experience something called paroxysmal nocturnal dyspnea, which is a symptom where they wake up from sleep gasping for air. This occurs because when they lay flat, there's an increase in venous return to the heart, and the heart already can't handle what it's getting while they're standing up, so that's going to lead to an exacerbation of that pulmonary congestion. Orthopnea describes the same pathophysiology as paroxysmal nocturnal dyspnea, except in orthopnea, the patient is awake. On auscultation of the lungs, crackles can often be heard due to a fluid accumulation in the alveoli in patients who have congestive heart failure. These sounds can be described as a popping sound that occurs during inspiration as the alveoli are popped open with the air that has been inhaled. In advanced stages of left-sided heart failure, fluid accumulation may be so severe that a frothy sputum, sometimes tinged with blood, may be coughed up by the patient. That's going to be due to small congested capillaries becoming so congested, so engorged, and having so much pressure on them, they actually burst, leading to intraalveolar hemorrhage. We'll talk more about intraalveolar hemorrhage in just a second, but before we do that, I want to remind you that, again, this is left-sided heart failure, inability to pump blood forward to the rest of the body, which means your patients may have fatigue, may report fatigue as one of their symptoms, as their muscles downstream from the left ventricle are no longer getting the oxygen and the nutrients that they need to properly function. The kidneys will also sense this decrease in perfusion, and they'll activate the renin-angiotensin-aldosterone system. Now, when that system gets activated, it actually results in a more fluid retention, which only worsens the heart failure. It exacerbates the heart failure symptoms. So let's go back to talking about this intraalveolar hemorrhage that occurs secondary to all this pulmonary congestion, this engorgement, and this increased pressure on pulmonary capillaries. This intraalveolar hemorrhage leads to a very specific subset of microscopic findings known as hemosiderin-laden macrophages, or heart failure cells. Again, the entire story of what we've been talking about with heart failure here really helps us to understand how heart failure cells come to be. You have this backup of fluid into the lungs, into the pulmonary circulation. Your pulmonary capillaries become engorged and dilated. There's increased pressure, and eventually they rupture and they spill red blood cells into the capillaries themselves, or into the alveoli themselves. Now, once the red blood cells are in the alveolar space, the macrophages in this area are tasked with cleaning those things up. So your macrophages start breaking down your red blood cells, and that will release hemoglobin within the macrophages. Now, normally the macrophages would just turn all of this into bilirubin, but when there's such a huge influx of hemoglobin, some of it's actually turned into hemosiderin, which is a iron-storing compound, and that iron-storing compound, hemosiderin, is going to stain this golden brown granule look whenever these macrophages are stained under Prussian blue stain. So you get this hemosiderin compound formation secondary to all this hemoglobin inside of your macrophages. And when you stain those macrophages with Prussian blue staining, you get this golden brown granule appearance to your macrophages. Now, let's talk about JVD. So JVD is actually one of the most severe signs that a patient can have on physical exam. It means that the left heart failure is so bad that not only is fluid backing up into the lungs, but it's backing up into the right heart so much that the right heart can't handle it, and it's backing up into the jugular vein, causing that jugular vein to distend and engorge, much in the same way we just discussed the pulmonary capillaries distending and engorging. So that's a significant feature of heart failure, and it is actually a really poor prognostic indicator for our patients. You should be really concerned if you see a patient with JVD as bad as the patient has it in this photo. That's one of the first things you should be looking for on your heart failure patients to assess how bad their heart failure is or how bad you think it is, and is something that you should report to your attendings on and put in your clinical notes as to whether or not you saw JVD on your physical exam. Now, instead of blood backing up into the jugular vein, another significant clinical feature of heart failure is hepatosplenomegaly. As blood backs up into, again, the systemic circulation, the liver and spleen can become congested, leading to their enlargement and creating a distinctive, uncomfortable sensation of fullness or pain in the right upper quadrant or left upper quadrant of the abdomen. If this gets left untreated, chronic passive congestion can lead to a condition known as nutmeg liver, due to the appearance of the liver, and eventually to cardiac cirrhosis, which is a serious and often irreversible condition. Patients with heart failure also frequently experience edema, specifically peripheral or dependent pitting edema. This occurs due to, again, that increased hydrostatic pressure within the systemic veins, which starts pushing fluid into the interstitial space of peripheral tissues. Common sites for edema include the lower extremities, and if you have a bedbound patient where this fluid in the interstitium is gravity dependent, you can have a buildup of it in the sacral area, which can worsen the formation of sacral ulcers and things that we know are not good for our bedbound patients. In severe cases, fluid accumulation can actually cause abdominal cavity ascites, so fluid within the abdominal cavity, as there's nowhere else for the fluid to go, so it quote-unquote third spaces and moves into these other spaces where it's the only place that it has left to go. Less commonly, you can see some of these heart failure patients get pleural effusions due to the increased pressures in the pulmonary circulation. If it's severe enough, it may cause shortness of breath on these pleural effusions. But in summary, the clinical features of left-sided heart failure are primarily due to that reduced cardiac output, reduced forward flow, and subsequent buildup of blood and fluid behind the left heart. Now, let's talk about right heart failure. The most common cause of right heart failure is actually left-sided heart failure. And again, here's how that happens. You have the left side not pumping blood. You get buildup into the pulmonary circulation. And then that buildup in the pulmonary circulation works its way into the right heart, and the right heart becomes strained. And that strain on the right heart eventually leads to failure, causing a right-sided heart failure secondary to the original left-sided heart failure. Apart from left-sided heart failure, however, there are some conditions which can cause an isolated right-sided heart failure. Chronic lung diseases such as COPD or pulmonary fibrosis, these can cause increases in the resistance to blood flow in the pulmonary circulation, resulting what is known as cor pulmonale, which is this right-sided, isolated right-sided heart failure that causes fluid buildup and hepatosplenomegaly and JVD all behind the right heart. This high resistance in the lungs, again, causes fluid to build up behind it, as the left heart is functioning just fine. It's receiving what it can from the right heart and pumping that out, but the right heart's just not giving it enough to really be at a normal physiologic state. There are some other causes, such as congenital disease, maybe a tetralogy of Fallot or atrial septal defects, anything in which there's a left to right shunt that is created, thereby increasing the fluid load on the right side of the heart, inducing stress and then possible subsequent right heart failure. Other causes can include pulmonary embolism, where the right heart must push forcefully against a blood clot in the lungs. That can cause strain on the right ventricle. And last but certainly not least, a right ventricular myocardial infarction could lead to right heart failure as the tissue dies, resulting in ineffective pumping. It's definitely worth mentioning the pulmonary fibrosis and other conditions that cause pulmonary fibrosis can be very high yield on test day, so make sure you review causes of pulmonary fibrosis and how to identify those in your question stems with physical and history so that you know how to identify isolated right heart failure from those etiologies. So because left-sided heart failure is the number one cause of right-sided heart failure, the symptoms of right-sided heart failure are often going to coexist with those of left-sided failure. And those conditions, left and right-sided heart failure, often are going to be occurring together. So I won't spend too much time talking about all of the things we've already talked about that we can see on physical exam. However, I will say that the trick here is that left heart failure can present with all of those same signs, but the question becomes, how do you tell the difference between left heart failure and an isolated right heart failure? You think of the left and right hearts as separate units with a pulmonary circuit lying in between the two. This way, you can distinguish left heart failure from isolated right heart failure at times by the presence or absence of pulmonary symptoms. Because as fluid backs up from the left heart, the first thing it hits is the lungs. But as fluid backs up from the right heart, it's not hitting the lungs. That fluid that's building up isn't building up into the lungs, it's building up in systemic circulation. So keep that in mind on test day and when you're in the clinic seeing patients on how you can differentiate left heart failure versus an isolated right heart failure. So this is a bit of an oversimplification, but you should look for those types of signs in the history and physical exam of the patient, and that may signify that underlying etiology of the isolated right heart failure, like the pulmonary fibrosis, the COPD, the other things that we mentioned earlier. Let's talk about diagnosis. The diagnosis of heart failure is typically made using a combination of clinical presentation, physical exam findings, lab tests, imaging, in some cases even diagnostic procedures. Let's delve into this process a little bit more in detail real quick. To start, the patient's history and physical are extremely important. You'll make most of your clinical diagnoses in your career off of your history and physical. However, patients with heart failure may present with symptoms, again, such as shortness of breath, that fatigue, weakness, swelling in the legs, that edema that we talked about. Sometimes they can even have rapid, irregular heartbeats. They may have like this persistent cough or wheezing, and they may have an increased need to urinate at night as that fluid continues to build up. Moreover, certain factors from the medical history, such as the history of coronary artery disease or hypertension or diabetes, can also point you towards heart failure. We've talked a lot about physical exams, so I won't talk about that too much here. However, there are some lab tests that are essential in confirming the diagnosis and understanding the severity of heart failure. An important biomarker is B-type natriuretic peptide, or BNP, and that's going to be produced and released by the ventricles in response to increased stretch and volume overload. And those are going to be two things that we see in heart failure that are going to increase the level of BNP in the blood. High levels of BNP are pretty indicative of heart failure. Imaging studies also play a pivotal role in the diagnosis of heart failure. An echocardiogram, which is seen here, can be used to see how well the heart is squeezing blood out, how well it is pumping. You can see here on the screen that this left ventricle is not pumping blood very well at all. You can use a chest x-ray to visualize the heart and lungs and look for fluid in the lungs. You can use an EKG to rule out any kind of arrhythmia that is causing the heart failure. And then if more information is needed, you can get a diagnostic procedure such as a cardiac stress test or CT or MRI or coronary angiography. All right, for the final segment, let's talk about treatment of heart failure. The management of heart failure is multimodal. It's going to be focusing on symptom relief, improving the quality of life, slowing down disease progression, and reducing mortality. The most commonly used treatment is going to be angiotensin converting enzyme inhibitors, or ACE inhibitors. These are medications such as enalapril or lisinopril, and they form the cornerstone of heart failure treatment. ACE inhibitors block the conversion of angiotensin 1 to angiotensin 2, which is a potent vasoconstrictor. As a result, they decrease systemic vascular resistance, reduce blood pressure, and lower afterload, all of which help to alleviate the strain on the heart in patients with heart failure. By blocking angiotensin 2's action, ACE inhibitors also reduce the secretion of aldosterone, a hormone that, as we discussed earlier, promotes sodium and water retention. Therefore, ACE inhibitors can also help alleviate fluid overload, which is associated with heart failure. Studies have shown that ACE inhibitors improve symptoms, slow disease progression, and decrease mortality in heart failure patients. Beta blockers, such as metoprolol or carvedilol, may also be standard treatments for your patients with heart failure. They work by blocking beta-adrenergic receptors, thereby reducing the heart rate and myocardial contractility. This decreases myocardial oxygen demand and the heart's workload, providing symptomatic relief. Beta blockers also have beneficial effects on the heart's structure and function over time, including a reduction in harmful cardiac remodeling processes. They have been shown to help improve survival and reduce hospitalizations for heart failure patients. Diuretics are often used for symptomatic management in heart failure patients. They increase that urinary output through medications such as furosemide or hydrochlorothiazide, and they help reduce the volume overload that leads to symptoms like edema and dyspnea. However, they do not directly improve the heart's function or reduce mortality. Next, you can use aldosterone antagonists, such as spironolactone or eplerenone. These drugs are often used in cases of moderate or severe heart failure. Aldosterone promotes, again, sodium and water retention, as we've been discussing, and increases that blood volume, thereby increasing the workload on the heart. By blocking aldosterone's action, these drugs reduce that fluid overload and counteract some of the harmful effects and harmful or uncomfortable, unpleasant symptoms that aldosterone can have on the heart, including that fibrosis and remodeling that we've been talking about. Lastly, there's a new class of drugs called angiotensin receptor neprilysin inhibitors. Again, this is a new class of medications that combine the benefits of angiotensin receptor blockers, or ARBs, with neprilysin inhibitors. Neprilysin is an enzyme that breaks down natriuretic peptides, such as BNP. Remember that natriuretic peptides are hormones that promote vasodilation and reduce fluid volume. So by inhibiting neprilysin, these drugs increase the levels of natriuretic peptides, promoting vasodilation, and subsequently they promote diuresis. At the same time, the ARB component blocks the effects of angiotensin 2, reducing vasoconstriction even further and reducing aldosterone secretion. In really severe cases of heart failure, where the heart's pumping function is significantly diminished, more invasive treatments such as ventricular assist devices or heart transplantation may be considered, but those are all going to be outside of the scope of step 1. All of these treatments that we've discussed aim to replace or assist the failing heart, but they are reserved for severe cases due to the risks and complexities associated with them. Remember, ACE inhibitors are first line. Almost all of your heart failure patients are going to get this. Beta blockers is second line. Almost all of your heart failure patients are going to have these drugs on board. Diuretics and these aldosterone antagonists can be used for symptomatic management as the disease progresses. The ARNIs are a new class of drugs that help with diuresis and maintaining vasodilation. And then remember, in these really, really bad patients, you can get ventricular assist devices or heart transplant. In conclusion, understanding these mechanisms that we've been talking about, the clinical features, the treatment approaches for both right and left-sided as well as biventricular heart failure is essential for optimal patient management in real life, as well as your examination on USMLE Step 1 exam or your cardiology shelves if your school does MBME exams. These concepts will all be building blocks for more advanced cardiology topics on your medical journey, so make sure you maintain this knowledge. Thanks for tuning in, and be sure to check out our other videos. Please remember to like, comment, or subscribe so that we can continue to provide free medical education resources to students around the world. If you find our videos useful at all, again, please be sure to let a friend know, and remember that you can catch all of our lectures for free on Spotify. We'll see you next time.